Dovid from Robert Wood Johnson Rutgers University, and the title of the presentation is Acute Colonic Pseudo-Obstruction.
Thank you very much for this opportunity in presenting a case. Tonight we'll discuss acute colonic pseudo-obstruction with pneumatosis. Neostigmine may still be an option. We had a 35-year-old female with no past medical history who was admitted electively for a THBSO for newly found cervical cancer. Other than the cervical cancer, she was a very healthy woman. Surgery went well without any complications, and then on post-op day 2, she developed abdominal pain, and the primary team performed a KUB. As you can see, there's significant dilation of the cecum, the right colon, and the transverse colon. At this time, the cecum was about 11 centimeters, and she was treated conservatively with NPO as a presumed ileus post-operatively. On post-op day 5, we were called, GI and surgery were both called, as she continued to have worsening symptoms. When I saw her, she had worsening right-sided abdominal pain with generalized abdominal pain. She had worsening abdominal distension. She had not had any flatus for over 24 hours, and she had small watery stools. At the time of consult, her vitals were remarkably stable, but her abdominal exam showed a tense, distended abdomen. Her abdominal tenderness was throughout her abdomen, but worse on the right side. She showed no rebound or guarding, but she did lack bowel sounds throughout her abdomen. Her labs showed hypokalemia and hypomagnesemia, but were otherwise within normal limits. At this time, we ordered a CAT scan. The CAT scan, as you can see, shows a dilated right colon with pneumatosis throughout the wall, and there was also pneumatosis seen within the cecum. At that time, we diagnosed her with acute colonic pseudo-obstruction with pneumatosis, or Dovid syndrome, and we ordered further labs due to the pneumatosis. A lactate was found to be normal, and amylase was found to be normal. These were ordered because lactate and amylase are used as markers for ischemia and possible colonic ischemia. The question was what to do now. This was a Sunday afternoon. She had failed conservative management for over 4 days. She had ongoing worsening abdominal pain, resist peritoneal signs. She had a dilated cecum, and she had pneumatosis. Was this a sign of ischemia in her colon? We know with regards to Ogilvy's that there's increased perforation rate with a cecum greater than 14 centimeters, or with time to decompression over 6 days. Although her cecum was not dilated to 14 centimeters, she was nearing that 6-day mark. With regards to treatments, you ideally would love to start with supportive treatment, but clearly she failed that, and so we were left with offering her a trial of pharmacologic treatment with neostigmine, endoscopic treatment with colonic decompression, and versus surgical approach. All of these treatments have their good and their bad, and they all are successful when they work, but they all come with risks. Endoscopically, a colonoscopy is associated with a 3% perforation risk and a 1% mortality, and surgery is associated with up to 44% mortality in patients with ischemia. And so we sat down with the patient and her husband and really discussed all these 3 options, and she decided that she wanted to try the neostigmine. We thought that it was appropriate for a trial of neostigmine, as she, other than the cervical cancer, she had no past medical history, making neostigmine a contraindication, and neostigmine has been shown to be very successful, although never been used in patients with pneumatosis. Of note, neostigmine has only been used or shown in the literature in small case series or individual case reports, and therefore it's never actually been FDA approved for this indication. Due to her decision, we transferred her to the ICU, and I pushed 2 milligrams of neostigmine over a 5-minute period. She seemed to have a pretty significant physical response. I sat with her for over an hour. She had a lot of gas. But the next morning when we performed a KUB due to some worsening abdominal distension and pain, as you can see, there's still a very significant dilation of the right colon cecum and transverse colon. Due to her continued stable labs and vitals, we then pushed a second dose of 2 milligrams of neostigmine, and this time she had an even more impressive physical response, and as you can see the next morning, her KUB showed a totally decompressed right colon and a much less distended transverse colon. Over the next several days, she continued to improve. Her abdominal distension decreased, her abdominal pain decreased. She was finally discharged on post-op day 10 with a prescription with Miralax, and I saw her in the office 6 weeks later, and at that point she was doing very well. Of note, she continues to follow with the GYN oncology team. She actually had a CAT scan 6 months after this episode, and the CAT scan showed no signs of pneumatosis at that time. I'd like to thank you, and I welcome any questions.
You must have been wearing your yarmulke when you pushed that in your statement. Okay, so you made the diagnosis on Sunday when no one was around.
We had the polar.
That was day 5.
Day 5.
And this x-ray was taken when?
That was post-op day 2. So 3 days.
Okay, so 3 days earlier, if you look, you can see that there's pneumatosis. This is not air in the colon lumen. So you could have made that diagnosis earlier than you did. This is pneumatosis here as well. And when you come back down, you clearly pointed out the pneumatosis in the right colon. This is pneumatosis linearis with a little bit of cystoides probably. And if we look at your follow-up study, this is not a normal film because in the cecum there is thumbprinting from submucosal edema. There's a little bit of transverse ridging, which is also from edema. So what I think you have here is pseudo-obstruction complicated by ischemic colitis. And I really think that you were very lucky that the woman survived your care.
We were very nervous. My attending and I were actually on the phone basically all of Sunday night with the colorectal surgeons also, because we knew we were taking a risk in what we were doing. But because she was 35, she had just gone through a pretty significant, or she went through a surgery but was otherwise very healthy. We wanted to at least give her the benefit of the doubt that we could try to avoid another risky procedure for her.
Well, I think you were lucky. I'm glad it worked out this way. I never would have done this. I think you were out of your mind. Any comments? Yes.
In your choices that you suggested to treat, did you consider use of methyl naltrexone?
She had only been given small amounts of, I think she had 3 doses of Dilaudid over the previous 3 days. We didn't think that there was, that narcotics was part of the.
Very often, that was a much safer trial with much less downside of treatment. Just a question, did you ever consider just putting her on her abdomen?
I'm sorry?
Tried to have her lie on her abdomen?
She was in a lot of pain. She even just, when I did a rectal exam just to confirm that there was no impaction, she was miserable. She was holding her husband's hands, like clenching, because she was so uncomfortable with the movement.
About 1986, I think it was, I reported on the association of pseudo-obstruction and ischemic colitis. And it usually involves the area of the colon that has the greatest diameter, which is the right side. Our case too spontaneously dissolved, so together we do something. Thank you.